Your TSH is normal, but every time you go in to get checked, you're experiencing all of the classic hypothyroid symptoms. But since your numbers look good, your doctor says that you're good to go. So what's actually going on here? In my practice, there's two common scenarios that I run into all the time. The first is that you've never been diagnosed with a thyroid problem before, and the normal TSH reaffirms that history, suggesting that you don't have a thyroid problem now, even though all your symptoms suggest otherwise. The second is that you've already been diagnosed with a thyroid condition. You've already been provided medication, and because the TSH is now normal, the medication must be working well and there's nothing left to do. So whatever symptoms you have remaining, well, your doctor says that's just something that you're gonna have to learn to live with. But here's the thing, just like anything else, labs have their limitations, and normal labs should not be a reason that we ignore worsening symptoms and a decrease in function. So in today's video, we're going to review our thyroid physiology. We'll talk about the most common reasons why someone might have normal TSH but continue to struggle with symptoms, and we'll help you understand what steps you should take next to figure out your diagnosis and the mechanism behind it. Hey guys, my name is Dr. Bodle, and thank you for joining me once again. I've been in practice for almost 8 years now, and I help people with Hashimoto's and hypothyroidism use natural strategies like nutrition, supplementation, and lifestyle changes to help improve their symptoms and get their lives back. I also release videos every Thursday on YouTube for people who are lacking support from their healthcare team and need more information, context, and strategies that they can use at home to start feeling better. If you've been enjoying the content, please remember to like this video, subscribe to the channel, and also ring the bell, which will let you know whenever new videos are available. But the first thing that we want to look at today is a breakdown of our thyroid pathway and physiology. And I know this probably isn't the most exciting thing, but it is really important for us. Many people can have thyroid symptoms that present in a similar way, but the mechanism or area of your thyroid pathway that has broken down can be different. The better that we can identify that area of breakdown, the better that we can support your system as an individual. So when it comes to our thyroid pathway, you probably already know that it all starts with our brain. If we have proper amounts of cortical activity, that's the outermost and newest part of the brain that contributes to a lot of our human traits and characteristics, that activity will feed down and stimulate our hypothalamus. From there, our hypothalamus releases a hormone called TRH, or thyrotropin releasing hormone. Thyrotropin releasing hormone then activates the anterior part of our pituitary gland, which releases the marker that most of us are familiar with, which is TSH, or thyroid stimulating hormone. The job of TSH is to do exactly what it sounds like. It's to stimulate our thyroid gland. And depending on the amount of thyroid hormone that is available or present in the bloodstream, something that our brain is always monitoring, the brain will either increase or decrease TSH depending on need and demand. If our thyroid hormone levels are looking a little bit low, or if our body needs to be more metabolically active, then our brain will increase our TSH. If our thyroid hormones are getting too high, or we need to reduce our metabolism, then our brain will decrease our TSH. So in a normal functioning system, we typically see an inverse pattern between our brain and our thyroid. High levels of TSH usually goes with low thyroid hormone and hypothyroid symptoms, and low TSH usually goes with high levels of thyroid hormone and hyperthyroid symptoms. And the reason that I wanted to just stress this a little bit and make sure that it's clear is because it's very common that people get confused and they think that because TSH is the only marker that's checked with thyroid function, that TSH is a product of our thyroid gland, and that's not the case. That can lead to further confusion because people think, oh, if my TSH is high, doesn't that mean my thyroid is producing too much hormone? But again, since it's not coming from the thyroid gland, that's why we have this sort of inverse pattern that I just described. However, without getting too far off track today, I did want to note that this particular pattern of classic hypothyroidism is all assuming that our brain is intact and working. It's what we refer to as primary hypothyroidism, where there's something wrong with the gland itself, and the brain is trying to compensate for the decrease in gland function by stimulating it more than it usually would. But for some people, they have an issue called secondary hypothyroidism. And this means that they could be having problems with their thyroid gland itself, or maybe the thyroid gland is doing just fine. However, in either scenario, something is wrong with the brain and it can't produce TSH like it normally would. If the thyroid gland isn't receiving any stimulating hormone, then it's not going to do its job. It's not going to produce thyroid hormone. Just keep in mind that for some people, they can have hypothyroid symptoms with low TSH that are either the direct cause of the hypothyroidism or a contributing factor to issues that their gland was already having. But once that TSH is released from our pituitary gland, travels through the bloodstream and binds to our thyroid gland, it is going to increase the production of thyroid hormone. This is primarily in the form of T4, which is the less active version of thyroid hormone, but there's also some production of T3. These thyroid hormones are then placed in what I like to think of as storage containers, which are called thyroid follicles, so they can be saved and released into the bloodstream when they're needed. Once that thyroid hormone is released, that T4 and T3 hitches a ride on binding globulins or transport proteins, which takes them to every cell in the body. Once they arrive at a cell that has demand for thyroid hormone, the T4 and T3 jump off the transport protein and become free T4 and free T3. The majority of that T4 will then be converted into either T3 or reverse T3 by local enzymes called deiodinases. This is another regulatory step or check that the body has, which allows it to adjust the amount of thyroid hormone that it needs locally depending on, once again, demand. Reverse T3 is mostly metabolically inactive, but the newly created T3 and the remaining T4 now are able to bind with the cellular receptors and drive cellular metabolism. That metabolism, or ability to produce energy, is going to allow our body to complete tasks and jobs. And that job is going to be dependent on whatever cell we're located in. If we can't make energy and essentially make things go, then, as I've said before, we tend to see things slow down and the most metabolically active areas tend to suffer first. This is why with hypothyroidism, we have the classic symptoms that we see all the time. The brain fog, the gut issues, hair loss, weight gain, low energy, brittle nails, and dry skin. All of these are highly metabolically active areas and they are suffering because they don't have the proper input. But now that we have a better understanding of our thyroid pathway, it brings us back to our original question. What if our TSH is normal? Doesn't that mean that everything else is fine? And of course, the answer is it's more complex than that. TSH, or the way that most doctors think about thyroid problems, is all about the quantity or the amount of thyroid hormone in our body. And definitely, if we have too little thyroid hormone or too much thyroid hormone, it can cause problems. However, many people with hypothyroid symptoms, although they may develop a quantity problem down the road, many of them are dealing with utilization issues, meaning that they have enough thyroid hormone in their bloodstream, and their brain is recognizing that and secreting a normal amount of TSH. But even though the amount is normal, their body isn't using it. And whether you don't have enough or you aren't using it properly, either scenario leads to the same endpoint: decreased metabolism and an onset of symptoms. So when your doctor says that your labs are normal and everything is fine, what they should really be saying is that your body is still producing enough thyroid hormone, or that you're taking the right amount of medication, which again, both of which are important. But the next thing they should say is, how are you feeling? Because even though the thyroid hormone levels might be normal, it doesn't mean that your body is using them efficiently or correctly. But now that we have a better understanding of our thyroid physiology, we have to ask ourselves, what could be interrupting our body's ability to use thyroid hormone, all while not changing our TSH? And although the exact numbers will vary depending on the research cited, for a majority of people, that interruption is caused by an autoimmune condition known as Hashimoto's. Autoimmune conditions occur when our immune system makes antibodies, which are proteins that are normally designed to help us fight off infections, instead for our own tissues. And Hashimoto's is when we make antibodies for proteins and enzymes within our thyroid gland. This antibody-mediated immune response leads to damage, fibrosis, and potential atrophy of the thyroid gland. And whenever we have damage to any tissue in the body, that creates an inflammatory response. This inflammation is a hallmark of autoimmunity, and it can actually impair our thyroid pathway at almost every step. Inflammation can downregulate brain function and decrease the release of TSH. As we said, the direct damage from the immune system can lead to impairment of our thyroid gland being able to produce adequate levels of thyroid hormone. Inflammation can also change the way that binding globulins grab onto and transport thyroid hormone. Once that thyroid hormone is released, remember it's primarily in the form of T4, well, that conversion process of T4 into T3, you got it, the conversion enzymes, those deiodinases, can also be impaired by inflammation. And finally, the cellular receptor that receives thyroid hormone, the thing that really turns the key and drives our metabolism, just like any other receptor in the body, inflammation can limit the function of that receptor and prevent thyroid hormone from binding efficiently. But although this autoimmune inflammatory response can lead to the classic hypothyroid findings, the elevated TSH and the decreased T4 production, that damage doesn't occur overnight, and autoimmunity is a progression. The problem is, most doctors aren't aware of this, and they're only looking for those hard findings. They're not considering the fact that in the beginning, that inflammatory process impairs multiple steps of our thyroid pathway, and even though the TSH and T4 hasn't changed yet, it can still cause someone to have symptoms in the buildup. So if you've been dealing with thyroid symptoms and sometimes feel like you're a little bit crazy, here's a quote that I lifted directly from research on Hashimoto's and the pathophysiology. Usually I try to memorize these things, but this one's a bit long. It reads, "The diagnosis of Hashimoto's is often challenging and may take time until later in the diagnostic process. The most common lab findings demonstrate an elevated TSH and low levels of free thyroxine, also known as T4, coupled with increased anti-thyroid peroxidase antibodies, which is also known as TPO antibodies, which is the marker most commonly checked when looking for Hashimoto's. However, earlier on in the course of the disease, patients may exhibit signs, symptoms, and laboratory findings of hypothyroidism, hyperthyroidism, or normal values. This is because the destruction of the thyroid gland and the thyroid gland cells may be intermittent. What this is essentially saying is that your labs and your signs and symptoms, especially in the beginning of the disease, will likely fluctuate. And depending on the immune system activity, inflammation, and progression of the disease, those standard lab values may look normal or slightly atypical to their doctor in terms of what they're expecting for a classic hypothyroid presentation. Think of it like this. Let's say you're out on a hike and you tweak your ankle. It's not too bad, you're able to finish the hike, but you definitely noticed it, and over the next few days, you notice some redness, swelling, and discomfort around that ankle. You obviously damaged tissue, and the tissue is inflamed. However, you can't get in to see your doctor for another week and a half, and by that point, you've been resting it, staying off of it, icing, and the ankle's looking a lot better. Your doctor says, yeah, it certainly sounds like you tweaked it, but it's just something that you're going to have to learn to live with and push through when the pain does occur. However, because he or she doesn't see any overt changes on your X-ray or MRI, there's nothing that they can do for you at this time. The testing is the gold standard in their mind, and because there's nothing on the testing, there's nothing to recommend. even though that ankle just doesn't feel right to you. So the years go by, you tweak that ankle a few more times, you notice that it doesn't respond very well when you're on it more frequently, and it eventually gets to the point where it's almost constantly swollen and uncomfortable for you. So you decide to go back in and give the doc another try. By this time, your doc is stunned. This is the same ankle that we looked at 3 years ago, and quickly recommends another MRI. Once they get the results, you've torn multiple ligaments, and the ones that still remain are only hanging on by a thread. It's so severe that typical rehab might not help you, and you could need surgery for this ankle. But did it really need to be this way? This is exactly what happens to many people with Hashimoto's. Because the changes to TSH and T4 occur late in the process and require extensive damage to the gland, most doctors don't catch it until extremely late in the process, if this is their only marker for assessment. However, as we said, that doesn't mean that you can't be having significant and extreme symptoms many years before that diagnosis is made. And that's all because of the immune system, the antibody activity, and the inflammation that goes with it that then impairs our body's ability to use thyroid hormone. So, one more time. In the early stages of Hashimoto's, we most often have enough thyroid hormone. But because of the inflammation, we can't utilize that thyroid hormone, and therefore the symptom presentation is the same. Whether the amount of thyroid hormone is too little or our cells aren't utilizing it, it still leads to a decrease in metabolism and therefore an increase in symptoms. The problem is, one of those scenarios our doctor recognizes and the other one they do not. And even in situations where Hashimoto's has progressed to the point where our thyroid gland is struggling to make thyroid hormone and people are provided with some sort of replacement medication, those people can struggle as well. And it goes back to those two common scenarios that I mentioned at the beginning of the video. You see, although they might need some medication to help normalize those levels, the real issue is the inflammation. And even though we normalize TSH through the use of medication, because the inflammation is still present and we're not managing the autoimmunity, we can have the same problem that we would have in the beginning stages of Hashimoto's. So if you're having thyroid symptoms and you're being told that your TSH looks fine, so don't worry about it, or just keep taking the medication like we told you before, and are suspicious that Hashimoto's might be a problem for you, there's a couple things that you can look for. First, you'll want to make sure that you add TPO antibodies and TG antibodies, also known as thyroglobulin antibodies, to the next thyroid panel that you have checked. TPO antibodies and or TG antibodies are positive in situations of thyroid autoimmunity. They can also be found in Graves' disease, but we have to correlate the presence of antibodies with the symptom presentation. If you have over and severe symptoms of hyperthyroidism and also have thyroid stimulating immunoglobulins present on your labs, then it's more likely to be Graves'. If you have positive TPO and or TG antibodies without the presence of TSI or TSH receptor antibodies, and you have hypothyroid symptoms or hyperthyroid symptoms or both, then it's more likely we're looking at Hashimoto's. Keep in mind that when you ask for these antibodies, your doctor might not be interested or care, and they'll often say that it doesn't change the diagnosis or it doesn't change the way that they go about providing care for you. Essentially, the medication provided will be the same no matter what the cause of hypothyroidism is. Additionally, autoimmune conditions tend to have a strong genetic component to them, so if you have a number of family members who also have thyroid issues, then it makes Hashimoto's more likely. Lastly, if we have a breakdown in any of our barrier systems, it can change the way that our immune system responds and increase the likelihood of developing autoimmunity. This includes things like our gut barrier, our lung barrier, our skin, and our blood-brain barrier. So if you've had chronic symptoms in any of these areas, whether it's chronic constipation and bloating, asthma, hives, and skin sensitivity, and now you're starting to develop more of those classical thyroid symptoms on top of it, then it only strengthens our argument to get those thyroid antibodies checked. So as the research paper said, the diagnosis can be challenging. But if all of these areas start to add up, then it's vitally important that you get properly assessed and you determine whether Hashimoto's is the cause of your symptoms. Although your doctor might not be interested, if we want to actually make changes and see improvements, we have to match our care plan and our strategies to the underlying cause of those symptoms. And the presence of Hashimoto's can and should dramatically change the way that you approach your thyroid health and the expectations that we have for your future. When we properly understand what's going on with our body, then we can expect to heal and thrive rather than just pushing through and learning to live with it. But I hope that this video gave you some good context and also provided you with some confidence that if you are experiencing and feeling this way, then trust your body. You're likely right, and even though the testing doesn't match it exactly yet, you need to go with your instinct. But if you have any questions on the topic, you can definitely leave them for me down below. Also, if this struggle sounds all too familiar to you and you're still dissatisfied with your healthcare team and would be interested in working with me one-on-one, then you can send me an email at contact@seattlethyroidhelp.com. Simply put in the subject line consult, and when my staff receives it, they'll reach out to you and see if you qualify for a free consultation. At the consultation, we'll discuss your health, your goals, and see if we're a good fit to work together. From there, we can decide together as a team if it's something that we want to move forward with. As always, I want to make sure that things are a good fit on your end, and I'd love to chat with you. If now isn't the right time for the consult and you're more interested in learning at home, then I have some resources for you as well. You can check out any of my free downloads down in the description box or peruse any of the videos on my channel. If you're looking to hear about some of the experiences that my patients have had working with me, then make sure to check out my testimonials. But that's all for now. Thanks for watching and hanging with me today. Please remember to like and subscribe. Follow me on social media. Links are down below. And I hope that you're continuing to progress and you're having an amazing week. My name is Dr. Bodle. I love you guys, and I will see you in the next one.